you communicate within the facility. You already have leaders and champions all in place who can influence a rapid scale up. Any infection control program will have, as part of their risk assessment, they assess what are the likely infections that are in our environment, and they prepare for it. They come up with an infection control plan, which would take into consideration things like Lassa fever, because it will be already in that plan that between December and April, we have an upsurge of Lassa fever, and things would have gone into place. They would have then prepared for it in terms of the resources that would be available. And of course, any infection prevention and control must be doing surveillance regularly. They're counting. What do we have? What are we seeing? So gradually, and of course, we also have challenges with our labs, but where we have labs, we're identifying. And of course, IPC also speaks to risk communication. When you have epidemics, you know how to talk to people. So the logistic and operational support come with an infection prevention and control system in place. Please, next slide. If we go to the specifics, the hospital management has a hospital emergency risk management program to manage the risk of internal and external emergencies, including epidemics. The personnel are fully aware of their roles in preparing for and responding to the emergency. I'm not going to read everything. There are effective communication lines needed for coordination. There are appropriate resources available. Next slide. The appropriate resources are available in sufficient quantities and are likely to be used effectively despite problems associated with an epidemic. And then you have due attention is paid to the physical, mental, emotional, and social needs of hospital staff and their families during an epidemic. The emergency response builds on existing knowledge, practice, capabilities, and capacities within the hospital and the health system and the community. Within the hospital, infection prevention and control builds the muscle, but it does not happen by chance. It does not happen when infection prevention and control is everybody's business. We all know everybody's business is nobody's business. Next slide, please. And when you look at the definition of infection prevention and control, one of the things you see in it, which is very critical, is that it is an ongoing activity. It doesn't stop. It doesn't wait for the next epidemic. It goes on whether there is an epidemic or not, because what it does is that it builds the system, it strengthens the system, it builds the right habits in healthcare professionals to ensure that they do not get infected when this unknown infection that we do not know how it will come or through what avenue it will arrive comes, because we would be practicing properly and doing the right things. And for these, you need people who drive it. Next slide. And so WHO came up with what we need for this system to be in place. The core components for effective IPC programs. Next. And for it to occur, the system to be what I call proofed against emergencies. In other words, you reduce the chances of healthcare workers dying. All these parts of that component must be implemented. Because if there is no IPC knowledge, no IPC system, no IPC organization, the resources are not, it is unlikely that a country or facility will be able to respond effectively to any outbreak. And this is what happens to us every time. Every time an outbreak occurs, we go into a frenzy of training. We go into a frenzy of looking for buying, everything goes into a frenzy. And while we're getting ready during the event, people are dying. Healthcare workers are getting infected. Then it also leads to healthcare workers being afraid. They leave their duty posts because they have not been used to running IPC. They have not had a chance to totally understand and recognize and learn to rely and trust the IPC system. So when you bring in IPC, and you will remember, for COVID, people were dressing up as though for Ebola, whereas the most important thing were their masks and the distance and ventilation. So the right knowledge so that you approach it properly occurs when that system is in place. Next slide. And when you look at the core components, it always says at national level, it says you should have a technical team of trained infection preventionists, including medical and nursing professionals. And then it says at health facility, it is critical for a functional IPC program to have dedicated trained professionals in every acute care facility. And you need a minimum ratio of 1 full-time or equivalent infection preventionist per 250 beds. In difficult areas or places where there's a lot of work, you could have it to 1 full-time to 100. It could even go down lower, depending on the amount of work that requires to be done. And this is a very strong recommendation. Please, next slide, please. The other part of IPC that gets people confused between being trained in IPC and being trained to keep yourself safe is that IPC is about training as well, amongst the other things it does. The IPC practitioner or professional must train. So we must train, first of all, the professional must be trained. So we have specialist training for IPC specialists. And what that training is all about is about putting systems in place to ensure that there is safety within the healthcare facility. And the other thing it does is being able to help other healthcare professionals protect themselves when they're carrying out their job. Then we train then we train healthcare workers so that when they're in training, when they're doing their job, they're safe. So those type of trainings are usually activity-based. When you're doing, you do your hand hygiene, you wear PPE for this, we train them so that when you're carrying out your job, you are trained. But that does not make you a professional. The professional does all that, plus putting systems in place. And that means they're working even when there's no problem. They're out to strengthen the system. And then we train those who are not clinical, but who are different support services, the people who are giving us food, the cleaners, all these people, because they will come in contact with pathogens. So next slide, please. So we need to remember that the training does not make everybody a professional. Now, for you to have that safety, we talk about being able to do everything. But we know that you cannot move from 0 to maximum in a very short time. And it can be discouraging when you have all the proper things in place. So the WHO came up with minimum requirements. And these minimum requirements are the standards that represent your starting point. In other words, for you to say you have a hospital, primary, secondary, or tertiary, there are minimum standards that you must start with. That is not where you end. The minimum requirements is not an end. It is a beginning. So it says for a tertiary, you begin here. For a primary, you begin here. The secondary, this is where you begin. Next slide, please. So at the national level, you must have at least 1 full-time focal point that is trained in IPC. We don't mean that was trained to wash their hands and wear PPE. Trained in the science of IPC, in the ability to set up the system. And then you must have a dedicated budget for implementation. Next slide. At the primary care level, you must have an IPC trained link person. We recognize that there are many primary care facilities and you may not have all the required training, but you must have somebody trained who reports to an IPC practitioner at a higher level of healthcare. They can be part-time, and there must be one IPC trained healthcare officer at the next administrative level to whom they report. In other words, from primary care, they must have somebody they can report to at the secondary level. And then you have secondary care. There must be a functional IPC program. You must have a trained IPC focal point, nurse or doctor, 1 to 250 beds. And they must be full-time and dedicated budget. And tertiary, in addition to what you have there, you must have, as a starting point, multidisciplinary committee and team. And there must be access to a microbiology laboratory. Next slide. So these IPC practitioners and professionals, what are they required to know? We have their competencies. Again, WHO came out with the core competencies for IPC professionals. And there are 5 areas and 16 domains. In the area of leadership and IPC program management, in microbiology and surveillance, in IPC in clinical practice. Most of IPC that is done outside epidemics are done within the healthcare facility, in neonatal units, preventing surgical site infections, neonatal infections, maternal infections. That's what IPC does. That's its day job. Epidemics are, the glamorous part of it, but that's not their main job. Their main job is in the clinics. And that's why the routine IPC person must have a clinical background and will work within the hospital. But during epidemics, all of the healthcare workers jump into play, because then we're working in the community, and the knowledge of IPC, what we're doing then is just putting out the standards for IPC, how to wash your hand, how to do this. They're not putting systems in place. For you to put a system in place in an acute care facility, you must understand what they're doing. And then education is another major part. The IPC professional must understand how to do adult education. And then quality, patient safety, and occupational health are other competencies that they must have. Next slide. And the specific abilities to achieve these competencies, they must demonstrate the ability to successfully carry out or contribute to policy and guidance, leadership and implementation, and all these other things that I talked about earlier. Next slide. They must also have some essential core behaviors. They must be passionate. There is no IPC person who can succeed if they cannot talk to people, if they cannot influence people, if they cannot carry people along, both their peers, their juniors, and their leaders. You must be able to advocate. Then they must be accountable for their own actions. You must do what you preach. They must be approachable. They must be communicative. They don't give up. They don't say things like, I told them yesterday they didn't do it. We all know that being told does not translate to practice. And even if they did it once, you need to constantly understanding the principles of IPC in terms of multimodal strategies. We know people will forget. So you have to continuously monitor. And then they must be thorough. They must be perceptive. Next slide. We're almost done. And, as I said, you must walk the talk. You must be a good leader, a team player. You must be a competent auditor. You must support individuals and teams. You audit what they do and you give them feedback, and then you must count. You must show that what you're doing works. So there's no way you do a good IPC without the surveillance and the feedback. Next slide. So we do have challenges. We don't have enough professionals. And we also have the challenge that we somehow along the line have confused the training we get as healthcare workers just to support and to prevent our personal infection and those around us to being an IPC practitioner. The training required for an IPC practitioner is deeper and continues because new information comes out about how to do it better. So right now in the country, we do not have a career path for IPC professionals, and we must have it, because people must be able to plan for their future. Otherwise, we will have what we do when we train people and they disappear. And we're going to have challenges with epidemics, because epidemics will continue to come. And we need somebody or some people who drive the system of IPC within facilities. We have very few functional IPC programs. Part of this has been due to the fact that we did not have IPC professionals. We're just beginning to develop them. And the ability to be competent and an expert means that those people trained must continue to practice. They will make mistakes, but if they do not practice and put the system in place because they're afraid that they're not perfect yet, we will not have these systems. We do have a few IPC courses on the continent, in some countries, and it is growing. Many African countries are beginning to have training for professionals, not just training for for healthcare workers. We have a lot of that. So there are still loads of training on the continent, but they're not for professionals. We need to have more of those. Next slide. And just to buttress what I'm saying, this was a study done years ago. But what they found was that the presence of trained IPC leads resulted in reduced rates of MDR infections and improved patient outcomes. Because those people are working, they're checking lists, they're saying the best way to ensure that staff continue to do what they do. We're human. We forget to wash our hands. We forget to do this. We don't have a system and we're not evaluating systems to see what really works. That's what an IPC professional does. Next slide. And we also found out that we have inadequate number of staff with specialized training. And what they found was that the inadequate numbers of staff with specialized training made it difficult to set up systems for IPC, because you needed somebody who would wake up and that's all they do. How do we put this system in place? How do we improve the system? How do we make sure healthcare workers are constantly trained and are doing what they need to do? Next slide. So in summary, somebody knowledgeable must be in charge of our facilities in the area of infection prevention if we're really going to solve the issues or reduce the rates of healthcare worker deaths and infections when epidemics come. So the need for trained IPC professionals is becoming incontrovertible. And the core competencies for IPC professionals by WHO has given us a framework for the development of this cadre of staff. And the amount of evidence that now exists in IPC requires in-depth knowledge and skills to be effective in creating a safe environment of care. IPC professionals have is a multidimensional field requiring competencies in leadership, program management, microbiology, surveillance, clinical practice, education, quality, patient safety, and occupational health. Next slide. So getting the facility or country prepared and ready for an epidemic does not begin during the epidemic. It starts before and must be maintained. And it requires a knowledgeable and skilled professional to get it done. It cannot be everybody's business. On that note, I would like to thank you all for listening. So, next slide. So we must have IPC professionals. It's their business. Their business is putting effective and functional systems in place to prevent and control infection. So thank you very much for listening.
Thank you so much, Prof. We really, really appreciate you taking out time out of your busy schedule to make this presentation. I mean, what a way to start the webinar with a very powerful presentation from the Vice Chancellor of University of Lagos. So we have two questions in the chat box. Ideally, we should actually have this at the end, but I don't know if you would like to quickly just take them before you go, and then we move on quickly to the next presentation. I know you have a few minutes
yes,
to your meeting. Okay, so
yes.
Is this fine by you? So one of the questions was with all the importance of IPC, why is it that, I'll just read it the way it is, the powers that be do not provide materials for IPC to healthcare workers in their health facilities? The second question is with regards to, can you explain the link between the WASH team in the healthcare facility and the IPC team? Thank you so much.
Okay, let me start with the first one. When IPC started in Nigeria, it was linked to healthcare associated infections. That was in the 70s and 80s. But with the advent of HIV, it suddenly became linked to epidemics, so that the powers that be did not see IPC as something that should be integrated into normal healthcare. We're just going back to the beginning now. We've gone full circle. We forgot about IPC being a clinical specialty, and that it is actually something that must be in the facilities at all times. So the programs came, and so you ended up with things like IPC, Lassa fever IPC, TB IPC. In fact, we start talking about healthcare worker safety. All these are just parts of a comprehensive IPC. You don't have that in developed countries. However, because they came with programs and came, with individual money for sorting these things out, it became very fragmented, and nobody saw it as an integral part of routine healthcare practice. But as we have gone through the whole epidemic thing, training people, each time training people, we've realized that it's not translating to improved care on the ground. It's not translating to reduced healthcare worker safety. It's not translating to our hospitals being better and cleaner, because we were so focused on epidemics, we were not building systems. So that's one part of it. The second part of it is that if you had a system, then it will be provided for. Everybody provides for the theater because we know it as a system, an operational system. We know what it does and we know what it needs. And there are people who wake up in the morning saying we need catgut. We need, we have so many operations a year. These are the things we need. We have nobody doing that for IPC. So it's always an emergency every time. And then we're all estimating. But if you have an IPC person, they know what they see as a normal. They know what the normal flow. There'll be Lassa fever throughout the year, I'm sure. So they will tell you, okay, in our hospital, we tend to see about 5 to 6 Lassa fever. We tend to see about 15 TB. So, and when things go up, we know we're going to, our surgery usually goes to about ×4. They plan for it. You can't plan for something you are not doing normally. So that's a part of it. The second part of it, and the last one, the second question, WASH, if you look at the core components of IPC, WASH is a major part. You can't do IPC without water and sanitation and hand hygiene. You can't. So it's a major component. The problem is that, again, we ended up with programs. So it's been done by mainly engineers, environmentalists. So what we now need to do is bring them together for them to see how that impacts them. So what we advocate is that IPC professionals must ensure that the WASH people in their facility see that what they do actually affects infection rates as well, so that they must be a team and they must be talking. And that's still part of the journey that we have to do. Thank you very much.
Thank you so much, Prof. This is deeply appreciated. We wish you a fruitful meeting. Thank you so much for it shows, your commitment and passion to the IPC movement globally as well. So this takes us to our immediate next presentation, which will be on the Nigeria's National IPC program, which is Turn Nigeria Orange, and the National IPC Coordinator and Chair of the committee will be making this presentation. Dr. Tochi, over to you.
Thank you, Yetunde, and thank you, Prof, for setting that very good tone for our discussion. So I'll be speaking on the efforts we are making at the Nigeria Center for Disease Control as we lead the National IPC program to, using Prof's word, building the system that is resilient in routine times and is able to scale up and be robust enough to take on the pressures that outbreaks of highly infectious diseases bring. So I'll be speaking about our National Infection Prevention and Control Program, the Turn Nigeria Orange. Next slide, please. Why do we bother with infection prevention and control? The discussions we've had so far, I believe, have really made it very clear that outbreaks are increasing in frequency, in scale, and in impact. And if we had any doubt before, 2020 was a great lesson. But prior to 2020, we had, as a country, been experiencing one outbreak after the other. And what has also become clear is that healthcare facilities that are supposed to be safe havens where we go and receive safe care can amplify these emerging infectious diseases and can even lead to these outbreaks going from the hospitals into the communities and even across borders. It is also clear right now that evidence-based IPC measures in health facilities are critical. We cannot provide good quality care, even in routine times, without infection prevention and control. And we definitely cannot control outbreaks during emergencies if we do not have infection prevention and control and practices that are evidence-based. And active IPC programs have been proven to be an effective approach. And what does it do? An active IPC program mitigates healthcare-associated infection transmission risks. So those day-to-day risks of infections being transmitted in our hospitals, each time there's that interaction with the healthcare system, it is an effective IPC program that helps to make it safer. And also, when we then have outbreaks, effective and active IPC programs contribute to the timely outbreak containment. So we must bother, and we do bother, with infection prevention and control. Next slide. The slide I have here is just to show how an outbreak or outbreaks, what the linkage is between outbreaks we've had in the country and our current infection prevention and control program. One of the critical outbreaks that had a good impact, a positive impact on our national IPC program was the 2014 Ebola outbreak. One thing that became clear during that outbreak was that it was largely nosocomial. The infection was largely among health workers. It was transmitted in health facilities, at least in our own context. It was something that happened in health facilities. And we had high numbers of health worker deaths. And a critical review and assessment of what happened showed that there were gaps. There were no truly functional IPC programs in the country. And even the little bits of infection prevention and control efforts that one could see were largely fragmented. And at that time, you couldn't point out who was an IPC professional in the country. There were some, but just very few. So it became clear that Nigeria as a country did not have trained IPC professionals to support the system during routine care and also support during outbreaks. And of course, there were lack of resources and largely no commitment. This led to and resulted in the development of an infection prevention and control training curriculum. That is the one now that is domiciled at the College of Medicine, University of Lagos at the CCAPS. And more importantly, this Ebola outbreak and the subsequent increasing numbers of cases in subsequent Lassa fever outbreaks was what formed the basis for the National IPC program at the Nigeria Center for Disease Control. Next slide. Here we see a brief history of infection control in Nigeria. I had mentioned about the fragmented efforts, how most of the efforts that were made for infection prevention and control in the country were largely in silos, and as Prof had mentioned in her own presentation, often dependent on who was funding which program, really not very coherent, wasn't based on systems, and therefore was not coordinated and couldn't deliver on that system that works. So you had TB IPC, you had Ebola IPC. When Lassa fever epidemics came, then you had the Lassa fever IPC. But to the point that we've been discussing all morning, there was no system in place. And that was why in 2019, at the Nigeria Center for Disease Control, a deliberate attempt was made to have a national IPC program in line with the WHO core components for an IPC program that will support both subnational entities, that is states, local governments, and health facilities in the country to set up infection prevention and control programs. Next slide, please. And that is the Turn Nigeria Orange, the national IPC program for Nigeria. What is Turn Nigeria Orange? It is a national IPC program which we work every day to make sure that it has strong links with other national programs, particularly our antimicrobial resistance program, our water sanitation and hygiene programs, environmental health programs, any relevant IPC program to support the implementation of IPC programs in the country. So for us, it is an implementation strategy we consider necessary for the successful implementation of WHO's core components of an IPC program. The color orange also, there's a little bit of a story behind the color orange. I will speak about that further. Next slide, please. So we'd like to mention that our IPC program, there are 3 important facts we always like to communicate about our national IPC program. The name, the Turn Nigeria Orange. We have an implementation strategy through Orange networks, and our philosophy, the One Nation, One Plan. To the name, sometime in 2017 in Africa, there was an IPC hand hygiene campaign that was going on, which is Turn Africa Orange. And we all know that in the world of infection prevention and control, orange is a color that denotes hygiene, hand hygiene. And when we were brainstorming and strategizing, we realized that in order for us to communicate effectively, we needed something that would help every Nigerian to connect to the national IPC program. And that is why we took the name Turn Nigeria Orange. For our implementation strategy, when we looked at the Nigeria healthcare landscape and the sort of systems we operated, and you have also seen the slide before where we saw all the different ways that we try to implement IPC in the country. We found that one of the strategies that could give us a competitive advantage is through the Orange networks. That is organizing health facilities in groups that will allow us to engage with them and work with them gradually to, for a start, meet the IPC minimum requirements with the intention of getting to the full core components. Then to the philosophy of One Nation, One Plan. Next slide. I will speak to the philosophy later. So the Turn Nigeria Orange was launched on May 5th, 2019, and the then chair of the Nigeria Senate Committee on Health, Senator Tejo Osho, launched it. And across the country, in hospitals across the country, given that it was also World Hand Hygiene Day that day, it was really launched and we got a lot of media representation. Next slide. So I have mentioned about our Orange network. Our Orange network is a network of health facilities across the country who will work together to set up IPC programs in line with the WHO core components to start out initially to meet the minimum requirements. And as Prof has described, these minimum requirements are those standards that should be in place at these health facilities to provide the minimum protection and safety to patients, health workers, and visitors. So we work with these networks to form the core, what we consider to be the core of an IPC program, which is trained, competent individuals who are working within a system to deliver on their mandate, usually in the form of IPC committees and IPC teams. We also work with them to do the needful, which is to form the basis to do all the assessments they need to do, all the baseline assessments and hand hygiene assessments, and then have that lead into an action plan. And we advocate with leadership of the health facilities for budgetary allocation and continuous mentoring and support. We continue to assess impact. definitely committed to sustaining the program on the long term. Next slide. At the health facility level, we also work with the leadership to ensure that they provide leadership and support for the IPC program and to make every effort to at least appropriate some funding for the board to fund the IPC program, particularly the annual work plans, and also to continue to check what the IPC personnel needs are and ensure that the necessary skills and knowledge is that are given access to whatever training they require to get the necessary skills and competencies. Next slide. And we follow a very deliberate approach, a stepwise approach. I said we start out with mentoring everybody to start with the minimum requirements. With the plan to get to the full requirement following this stepwise approach. Next slide. This is the full developmental cycle of the Orange Network. And this year in, year out, we continue to work with the networks to continue to strengthen and improve and demonstrate impact, following the planning, advocacy through the baseline assessments to work plan development, routine activities, including the monitoring and auditing of activities, and then peer learning and mentorship opportunities, continuously advocating and pushing for sustainable funding and using research to improve practices. Next slide, please. So currently in our Orange Network, we have our first cohort of the Orange Network, which are now 41 public tertiary health facilities in the country. We have other Orange Network, the Open Orange Networks, who are currently over nearly 120 or thereabout, and they're made up of both secondary health facilities and some tertiary health facilities. And we're also working with the National Primary Healthcare Development Agency to get the networks of primary healthcare facilities on board. These numbers continue to expand every day. Next slide. So the point we are making here is that we are very careful to build on solid foundations. The IPC program is very, very important. And then we support with guidelines. We work with training institutions for education and training. We make every effort, and we are currently now in the process of making sure that we deploy our national healthcare-associated infection surveillance, including for epidemic-prone diseases such as Lassa fever. Monitoring, audit, and feedback is what we continue to develop audit tools, and we continue to work on platforms for deploying these tools and also for receiving feedback and sending back feedback to reporting health facilities. Next slide. So at the NCDC, at the National IPC program, we work to continue to provide leadership, to provide opportunities to hospitals in the country, to wherever the resources are that can help them to improve their IPC program. We embark on advocacy and strategic engagement. We provide technical guidelines. We work to build the capacity of health workers, both the frontline health workers and the IPC professionals. We constantly engage in monitoring, evaluation, and learning. And one of our very important strategies is constant stakeholder mobilization on the built environment and all the other components. I've also mentioned our philosophy, the One Nation, One Plan. And why we have this philosophy is that we realize that while we may be the National Infection Prevention and Control Program in the country, the work of IPC to be successful, we must bring everybody and take a multi-sectoral approach. Health workers, health managers, policymakers, patients, everybody must be involved either in the form of advocacy or in making budgetary allocations or whatever way that everybody can chip in to strengthen IPC in the country. Next slide, please. So we want together to make sure that IPC is the norm and not the exception. And that preventing IPC, patient safety, and quality healthcare is a priority in every health facility, and that we also all work together to keep our health workers safe. Next slide. So, how have we really shown this One Nation, One Plan? We planned together with the College of Medicine, University of Lagos, and thanks to Professor Ogunshola and the team, to train IPC professionals based on a needs assessment where we have tried to work out the numbers of IPC professionals we need, given what we know about the number of health facilities in the country. So we plan together to get IPC professionals who are trained and who have the core competencies for IPC professionals, starting from the basic course through the intermediate to the advanced. It's part of how we implement our philosophy of One Nation, One Plan. Next slide. This is a cohort that's gone through the intermediate IPC course. Next slide. We also, as part of our One Nation, One Plan and stakeholder engagement, have our annual engagement with chief medical directors and the leadership of the Federal Ministry of Health. And this is one activity that is very, very important to us. It helps us to communicate the vision. It helps us to advocate for strengthening IPC programs in health facilities with the chief medical directors of hospitals in the country. And we hope to continue to expand this engagement to cover secondary health facilities and working through the associations of private hospitals to begin to get the leadership of private hospitals into this sort of discussion. So 3 years in a row, we've successfully brought the chief medical directors together to have discussions on how to strengthen IPC programs, including controlling and making available what is required to control Lassa fever. So this is this year's chief medical directors engagement. Next slide, please. We embark on media chats, Twitter chats, whatever it takes to convene, to bring everybody around the table to have the discussion on how to strengthen infection prevention and control. Next slide. Now, as I wind up, I'd like to talk about what we do for IPC in outbreak preparedness, readiness, and response. And WHO shows that strengthening IPC preparedness and readiness will lead to a more robust response. It will help to contain outbreaks and prevent health systems from becoming overwhelmed. Next slide. So we follow this model in our approach for preparing for, being ready for, and in responding to outbreaks of those diseases of public health importance that we are particularly concerned with in the country, and Lassa fever is one of them. So for our IPC work at the National IPC Program, we work to make sure that we work with the stakeholders, both at the national and at the sub-national, to put things in place during the preparedness phase. And that is everything we do to build IPC programs, to build systems that work, so that when we get to response phase, we'll not use the very popular phrase that really we are using during COVID, building the ship while we are sailing. We try to build the ship before the outbreak, years, months before the outbreak, with all the things we do during the preparedness phase. And that is why we pay good attention to making sure that there are competent people managing IPC programs. There are guidelines. There are tools for monitoring and auditing. There's capacity for staff, beds, occupancy, that we do advocate for all that. Everything we do to strengthen the IPC program is during the preparedness phase. And then as we move to the readiness phase, it then would depend on the nature of the outbreak. If it's Lassa fever, we know the time of year, 6 months or thereabout to when we know that we'll have peak cases. We then begin to engage with the health facilities in a way that we ask them, audit your systems, test run your systems, ensure you have your stockpiles ready, train your frontline health workers so that they're able to do whatever they need to do for standard precautions, improve index of suspicion, make sure that all your systems are ongoing so that when we are in response phase, would then be to deploy all those already tested systems. Next slide. So that's really what we follow. And for all that, there are some things we do during the immediate phase, some we do during the early phase, some during the advanced, both for the preparedness phase, the readiness phase, and the response. And it becomes clear that as a national IPC program, we cannot do this if we do not have our equivalent at the state and health facility level who we liaise with. We definitely cannot engage with every health worker, and it will be very inefficient, it will be very ineffective. That is why we have worked hard to establish a network of IPC focal persons across the states in Nigeria, and we are now deliberately and gradually working through them and with them to set up IPC programs in as many health facilities across the country as possible, with the hope that over time this will become the norm rather than the exception. Next slide, please. So this shows the distribution of IPC trained professionals that we have in the state. So you see, we still have a long way to go. The green is where we have up to 11 to 59 IPC trained professionals. And when we say IPC trained professionals, these are people who we have their data from the College of Medicine, University of Lagos, and who we have also supported through our national IPC program to acquire these trainings. So we are targeting that over time, the whole of the country will be green. Next slide. Other things we have also produced and we continue to disseminate and we continue to make available to every health facility, all the IPC focal persons, and all the health workers in the country are the infection prevention and control, information, education, and communication materials. We have those ones on standard precautions, the whole range of standard precautions, because for a health worker to work efficiently, it has to be supported with the right kind of materials. We have to make it easy for the health worker to make the right choice. So we produce all these materials, and my colleagues will share the link to all these in the chat box if it's possible to do that. And specifically for infection prevention and control, we have the National Guide for Lassa fever. In 2020, we had our first edition of infection prevention and control for viral hemorrhagic fever that focused specifically on Lassa fever, with some components for Ebola. And we have just now reviewed it. We now have a second edition, the August 2023 edition, the National Guidelines on Infection Prevention and Control for Viral Hemorrhagic Fevers. This now we have incorporated the Marburg, and we have also now strengthened the aspects that makes the case on how to establish IPC programs in health facilities. And we have also revisited the case definitions for Lassa, Ebola, and Marburg, working with our surveillance team. We will also make all these available, the new edition available through the links, and if we have your contacts. Next slide, please. I would like to show what difference we have made. Before 2023, the IPC was not part of the joint external evaluation, but we are happy to say that with the just concluded joint external evaluation, for the first time, IPC was part of the indicators that is being tracked. And all the things we have discussed here had helped the country to at least show some progress in the aspects of infection prevention and control that the joint external evaluation is tracking. And we are hoping that next time when we do this, we'll have demonstrated very good progress, as we are targeting that about 75% of hospitals in Nigeria will have a functional infection prevention and control program that meets IPC minimum requirements. Next slide. So this is the journey our IPC program, the vision in pictures. We are hoping that as we constantly work to strengthen all the components of the IPC core components, and working with all the stakeholders, IPC professionals, hospital administrators, improving programs, providing evidence-based guidelines, education and training, surveillance, monitoring and audits, paying attention on the built environment, including the water, sanitation, and hygiene infrastructure, and doing all that, utilizing what we call the multimodal strategies, that we will provide an environment of health in hospitals that is safer, where health workers are safer, and where health workers can actually manage Lassa fever cases and indeed other cases of highly infectious disease, whether they know what they're dealing with initially or not, but can manage that without compromising the system, where everybody remains safe and we no longer have the loss of health workers and indeed the loss of patients. So that is the vision we have for our national IPC program. Next slide. And at this, I'll say thank you, and I'll be very happy to take questions now or later.
All right, thank you so much. We are really happy with the progress so far, and this is a very good way to also build on what Prof has said. So in a way, everything is just aligning. There were some questions I was also able to attend to in the chat box with regards to, start building the system. So I will get back to the rest of the questions eventually, but for now, we'll quickly move on to the next two presentations, and then afterwards, we'll have a question and answer session. Charity, please bring up the next presentation on the agenda. Okay, so our next presenter is Dr. Ezema Godian, and he'll be taking a presentation on Lassa fever outbreak preparedness. He's the IPC focal person professional at the Nigerian Air Force Military Base Hospital in Makurdi. Over to you, sir. You have the floor. Thank you so much.
All right. Good morning, everyone. Can you hear me?
Yes, can hear you loud and clear.
Right.
Go on.
Yeah,
Thank
good.
you.
I'm presenting the Lassa fever outbreak preparedness benefits of IPC program in a healthcare facility prone to Lassa fever outbreak. The case of 161 Hospital Makurdi. Invariably, at this moment, I am the IPC focal person, Dr. Fali. I was the IPC focal person. I've trained others to take over from me. So that's just to let you know. So as introduction, Lassa fever, as we all know, is a viral hemorrhagic fever caused by Lassa virus. It's a single-stranded RNA virus, family of RNA viridae, and it's transmitted by multi-mammate rats, or what we call mystomies rats. So, and of course, in West Africa, about 300,000 to 500,000 annually. Outbreak occurs in health facility with high mortality, high fatality of about 36 to 65%. I'm sure that many of us must have known about a health facility or a friend who works in a facility who have been infected, either died or survived with some palpitation by all healthcare workers. Benue State, as we all know, is also one of the states that actually is where Lassa fever is endemic. Prior to the presentation, the case we had in Makurdi in 2021, in 2020, we had about 108 suspected cases and 10 confirmed, with 4 deaths in Benue State. And due to the associated high mortality in health facilities, there's usually panic and abandonment of suspected cases, and also poor management and poor outcome. And that was actually what happened in 2021 when we had some outbreak in Benue State. A lot of people didn't want to get associated with anything Lassa fever because of the fear of getting nosocomial infection. Next slide. So 161 NAF Hospital is in NAF base Makurdi, and is a specialized secondary health facility with 99 bed space with 10 isolation rooms, and is also a center for infection. It has a center for infectious disease control with over 5,000 active persons with HIV they are managing. Also, it has been actually a center that have helped in terms of TB management, and had a gene expert. It was one of the first facilities to have gene expert in Benue State, and where it's actually reached out to other facilities for management of drug resistant tuberculosis, and also has a specialized laboratory with COVID-19 PCR assay. So during the COVID-19, 161 NAF Hospital was also a hub for diagnosing of COVID-19. Proceed, please. Next slide. Next slide. Hello. Next slide. Hello.
Charity, next slide, please.
Okay. In terms of the IPC, the story of IPC in the facility, incidentally, just before Ebola case came up. That was the first time we started with, go back please. That was the first time we had our IPC. Please go back. Is she hearing me?
I can hear you, sir. It's the network that is unstable.
Okay, good. So in 20...
The next slide, Charity. Yes.
All right. So the story of the IPC program in the facility, before the Ebola started case in Nigeria, we just started the IPC. That was the first time we set the first IPC committee. And at that point in time, there was no IPC policy document. There was no policy document in the facility. And then unfortunately, as a military facility, there was regular transfer of healthcare workers. So when we set the committee, as you are trying to build, people are going and you are here with new staff that don't have much idea about IPC. And also, at that point in time, there was no clear role for the committee. We didn't know much about what to do. And then there was also minimal capacity building, capacity of among the committee as well as the healthcare workers. Then in 2018, after a while, after going to and fro, we now have to set a new committee. That was when a new committee was set, and then where the committee was now mandated to draft a policy. And then that was the first time we had a real IPC team that was formed. And then we had opportunity, the people who are members of the IPC committee had opportunities to now have their capacity build. They had the professionals, they become, they had training, basic IPC trainings, the intermediate as well as the advanced IPC training. And then in short, we instituted regular IPC training for all healthcare workers. That was every quarter, there would be a training to make sure that every healthcare worker within the facility get trained in IPC at least once a year. Proceed. So unfortunately for us, the Orange Network also came up, and then actually the facility was also selected among the Orange Network committee, Orange Network in the country, and it helped us actually to find our fitting. And then we had the diploma in IPC, was the IPC for company had the diploma in IPC. Then also there's also other training by health implementation plan, and then there's a quarterly training and review meeting for the IPC team and committee, and at least, like I said before, a training for each healthcare worker in the facility for at least once a year. Proceed. So the outbreak that occurred in 2021, which where we are going to draw our information from, in that 2021, we had 6 confirmed cases of Lassa fever and 3 suspected cases. And these 3 suspected cases, 2 we never got the result. 1, when they got the result, they say it's not positive, though the patient had symptoms and was managed in line with Lassa fever. Then we had 1 death, and that 1 death was the first case we had. Unfortunately, when we had the case, we had high index of suspicion, but there was no ribavirin within the state. So we tried everything to get ribavirin within the state. We couldn't find it. We called Abuja until we were able to get some from Nasarawa, a neighboring state. That was almost about 4 or 5 days after diagnosis was made. And then this patient could not make it because of the delay in commencing treatment. But the good thing is that no healthcare worker was infected within that period, and there was no outbreak within the facility. Proceed, next one. Go ahead, please. Now, the scenario, pre and post Lassa fever. 1, the findings. When after the outbreak management in the facility, and there was a successful, there was a success story. Most of the patients got well, and there was no outbreak within the facility. No healthcare worker was infected. A lot of people came around to say, what did you do? And then we said, we need to document what actually happened within the facility so that others will learn and then be able to see that Lassa fever is not a death sentence in the facilities. And one thing, when the questionnaire was shared among the facilities and the healthcare workers, one thing that stood out were this. 1, there was high index of suspicion among healthcare workers, which was attributed to regular IPC training. 2, there was the presence of IPC team led by the IPC practitioners that ensured that healthcare workers adhered to the IPC protocol in the facility, whether there was Lassa fever or no Lassa fever, that adherence to IPC protocol was there. And also there was a regular IPC training that ensured that every healthcare worker was aware of the basic IPC strategies for managing infectious diseases. And then fourthly, the facility has IPC protocol for management of suspected Lassa fever and other highly infectious diseases, which is available at all hospital stations. So it's wherever you are, you'll be able to see posted if there this patient come with fever, diseases, do this. So everybody knows the next thing to do. So when a patient comes with fever, whether it is Lassa or any other case, these are the protocol that is already a guideline. So it's easy for people to follow, and there are people going around to remind them that this is what you should do. Although the facility has no IDs isolation ward or specific staff dedicated to Lassa fever case management, there was a good workflow to minimize contamination of hospital environment. This was very key to making sure that the environment is safe, that even when the patient comes in and nobody knows whether it is Lassa or whatever it should be, that patient will manage as if it is a highly infectious disease, so that there will be no running helter-skelter at the end of the management of any patient. Next slide. So when these are the outcome, the survey that was done, these are the number of patients. These are people who actually had any contact with any of those patients that came around that was either suspected or managed case, suspected or confirmed case of Lassa fever. And then see this is the summary of the people that were interviewed, and you see there are a total of 19 healthcare workers, and most of them are married, and the majority of them were nurses, 7 are doctors, and then 2 cleaners. Please proceed. Now, the key thing that was found was that for IPC training, 19 of them actually had an IPC training. That's very key. And then, interestingly, for 13 of them had IPC training less than 4 weeks before that first case. They had contact with that Lassa fever case, but only 6 had greater than 4 weeks. That tells you that there's a routine process of training healthcare workers, not waiting for outbreak to occur before training occurs. Then there's also Lassa fever specific training, but only 6 had Lassa fever specific training. And one good thing is that once there's a routine process, routine training, and the system built, whether it is Lassa fever specific or not, every healthcare worker knows what to do. It doesn't matter whether it is Ebola specific IPC training. It is a universal training that every healthcare worker knows, and that was very key that helped in that facility. And then in terms of anxiety, you found out that 9 of them had 47% had mild anxiety, and that was because of the training they've had. They know what next to do. Moderate anxiety was found in 9. Only 1 person said he has severe anxiety for knowing that he had a contact with Lassa fever. Then PEP, post-exposure prophylaxis, only 1 person actually had post-exposure prophylaxis. And that person who had post-exposure prophylaxis was actually a visiting consultant. And that visiting consultant did not have that opportunity to have an intensive IPC training. And that was actually why we have to place that person on PEP. Otherwise, every other person was a staff of the facility, did not have any need for that post-exposure prophylaxis after encounter with Lassa fever case. Proceed. Now, what are the common IPC strategies employed by healthcare workers? Found out that regular hand hygiene was one of the every person that is in that facility who had a contact with this this patient said that they had regular hand hygiene, and that was very, very key. And also the use of alcohol hand rub was also among all of them that were asked, said they were using a alcohol hand rub. They had their own personal one they put in their pocket, and also in the facilities there were alcohol hand rub. The hand gloves were also used. And one key thing about this facility is that every healthcare worker was trained on how to remove and dispose hand gloves, which could be a source of infection if it's not properly done. Then surgical mask also by 100%. Then other ones, including N95, was the minimum, the least. Only people who use N95 were people who had to do aerosol generating activities among these Lassa fever cases. Otherwise, every other person used the basic PPE and were never exposed to Lassa fever. Next slide, please. So in conclusion, from what we saw and what we have done in that facility shows that good IPC knowledge and practice are essential in preventing the nosocomial spread of Lassa fever. That's exactly what we saw in 161 NAF Hospital Makurdi. And those involved in invasive procedure and aerosol generating activities require special PPE, such as N95 and coverall. So if you have to do something like resuscitation or something like intubation, in that case, you must have to use that specialized PPE. Otherwise, you may get yourself infected. Then Lassa fever can be successfully managed in a secondary health facility where IPC is institutionalized as seen in 165 NAF Hospital, Makurdi. Next slide, please. So thank you very much for listening to me. I try to make sure that we finish on time so that I covered it. I don't spend much time. I've seen that already I started a little late. Thank you very much, and God bless.
Thank you so much, Dr. Ezema. You did a very wonderful job and also tried to save us a lot of time. We are really grateful for that. And what a very beautiful way to see the importance of having IPC in a healthcare facility. I'm sure other facilities that have not been enrolled in the network will also be itching and trying to reach out to the coordinator of the project. Thank you so much for that. So we're going to go to the final presentation, and this will be taken by Professor Stephen Abba, the Deputy Vice Chancellor Academic, Federal University of Health, Otukpo. Thank you so much, and over to you, sir. Hello, Professor Abba.
Good morning.
Good morning,
Can
sir.
you
You
hear
have
me?
the floor. Yes, we can hear you. Thank you so much.
Okay. Let me start by acknowledging the great presentations by the previous speakers, Professor Ogunshola, our own Doyen of IPC, Dr. Tochi Okwo, and my friend, Dr. Godian. They have laid a very good foundation for my presentation, which is on strengthening occupational safety, a comprehensive approach to preventing and managing health worker acquisition of Lassa fever. The issue of occupational acquisition of Lassa fever is one that the importance cannot be overemphasized because of the multiple effects that it can have on our health system. I will start by giving a brief, very brief overview of the epidemiologic landscape of Lassa fever in Nigeria, because we cannot be talking about safety if we don't really understand the epidemiology of the disease. And so basically, we know that Lassa fever is one that is characterized by a seasonal pattern. Although we also know that in Nigeria, the diagnosis of Lassa fever occurs all year round. And this transmission is influenced by the environmental factors, including the rodent behavior, the mascomis, and also the food availability. Next slide, please. Yeah, we also know that in terms of the epidemiology of the disease, the burden is higher in the states of Edo, Ondo, Ebonyi, and more recently, the north central states of Nasarawa, Bauchi, and Benue. Between 2018 and 2020, the number of cases have doubled. And we also know that this year alone, within the week 40, based on NCDC records, we have had 28 states that have recorded at least one confirmed case. And this was spread across 113 local government areas. The interesting thing is that 75% of all confirmed cases were reported in Ondo, Edo, Bauchi, in the proportions of 25%, 35%, 29%, and 11% respectively for Edo, for Ondo, Edo, and Bauchi states. So that is the landscape, that is the epidemiology. In terms of body, we know that this is essentially a West African disease. Next slide, please. And the disease is transmitted via two important pathways. We have the transmission from the reservoir, which is the mastomys rat, and primary infections occur in 80 to 90% of humans, either through food, through household items, or through infected materials contaminated by the rat droppings, rat urine, rat feces, or through direct contact, through the handling of the mastomys itself. Secondary transmission occurs as human-to-human transmission, and here contact with body fluids, particularly with blood, with secretions, and other infected materials. And this is one of the areas where occupational acquisition of disease comes mainly, particularly that health workers come in close contact with body fluids of patients. Next slide, please. Now, the spectrum of the disease, Lassa fever can present in various forms, and it can present asymptomatically. And we also have the spectrum ranging from fever, extreme fatigue, general malaise, to headache, sore throat, diarrhea, vomiting. And by the time we begin to see features of hemorrhage, we know that we are getting into the complication stage of the disease. And this is where we may begin to see complications, renal complications, which may present in forms of face swelling, low blood pressure, and other forms of manifestations of kidney derailment. Next slide, please. Now, from this is probably old records, but we do know that in terms of the actual burden of the disease, over 58 million people are at risk, and 5,000 estimated number of deaths in West Africa every year. We also know that the rural areas share a heavy load of this burden. And in the West African sub-region, the states of Senegal, Sierra Leone, Liberia, Nigeria are heavy hit by this, by Lassa fever. Next slide, please. Now, in terms, what is the significance of occupational safety in Lassa fever? Quickly, we'll look at three very important aspects. The first one is that health workers are at high risk of occupational acquisition by virtue of the nature of the work itself, which brings them in close proximity to the patients and their body fluids. We also know that when health workers become infected by disease, they impact directly on the health system, particularly in terms of the human resource that is the grease of the oil system, of the health systems. So once we have a critical mass of health workers coming down with infection, it impacts on their productivity, it impacts on decision making, and so on. And so the broader effect on the control of disease is compromised. And as we'll see in the next slide, there are several manifestations of this. In terms of disruption of healthcare services, the functions that are performed by these health workers, once they can no longer perform them, a gap exists, and that can disrupt, particularly for specialist services. Then that imposes an increased workload on the remaining staff, who are now forced to share the workload. And you already know how our health system is in terms of human resources. Now that we have a huge shortage of specialized and skilled health workers, once we are not having optimum service, this can tilt the balance in the provision of health service. And that will begin to put a strain on the available resources, because health workers, once they are down, attention is diverted to them by their colleagues, and the infrastructure to support the management of these patients, the slim resources, like we've heard from the previous speakers, we already have a gap in the healthcare infrastructure. This will put a further strain on it. And again, on resources, resource allocation, materials for IPC, materials to care for these patients. If you have one patient in the isolation unit, you can imagine the number of health workers that need to attend to these patients, to take blood samples, nurses to look after and care for this patient, and so on and so forth. So overall, the impact of health worker morbidity from Lassa fever is huge and it's multidimensional. And so it is one that is of great significance to the economy of every country. Next slide, please. Now, once health workers begin to come down with the disease, the community as a whole is impacted, because they begin to wonder if health workers themselves can come down with the disease, then it is a big issue. And also, it begins to have ripple effects, because these health workers live within the community. And so the trust that community members may have will be impacted as well. And that will directly also impact on public health response. In the outbreak of 2018, 2019, we saw a lot of this, because a number of health workers came down with the disease. And then we began to have issues of a lot of rumors and false information and so on and so forth. This in itself will have economic consequences. Many health workers are breadwinners in their homes. Many of them are decision makers in their communities. And so when they are not available to perform these vital roles, it has economic consequences. And not to talk about the long-term effects. This will have ripple effects, and as a consequence, particularly when there is mortality resulting from the disease, it could have long-term consequences, both on the health worker, immediate family, the community as a whole, and the country at large. Next slide. Now, let's quickly identify the high-risk areas in the healthcare settings. We have emergency rooms. For obvious reasons, these are sometimes the first point of call for febrile patients. And because of the nature of Lassa fever itself, many patients present with malaria-like illness. And when they are received at the emergency rooms, many times Lassa fever is not the first diagnosis, and this could lead to transmission of or contact with body fluids of such infected persons. Now, in the ICU unit, because of the requirement for close monitoring, because of the frequency by which these patients need to be monitored, health workers come in close contact with these ill patients. This again increases their risk of contact with their body fluids and transmission of Lassa fever. In the laboratory, oftentimes the blood samples may not be well packaged, they may not be well managed, and where you have inappropriate handling of such samples, you could have accidental contacts and increased risk of accidental exposure to these body fluids. The one unique feature about Lassa fever is that it can be transmitted even when the patient is dead. And the mortuary is one area where we regard as a high-risk area in the healthcare setting for the transmission of the disease. And mortuary attendants oftentimes come down with exposures, heightened exposures to the body.
Okay, hello, Prof. Can't seem to hear you. Hello, Prof. Professor Abba, we can't hear you. Okay, so I think we just lost Prof. He just probably his network. I'm sure he'll be trying to join back soon, but we've lost the connection with him. So just bear with us, please. Let's give him just a few seconds to rejoin. Charity, how many more slides?
So there are about 27 slides left.
Okay. Okay, so let's just give him a minute, and then try and reach out just to make sure.
Give me 1 minute. I'm trying to get him to see if he can use another device. 1 minute,
All
please.
right, thank you so much.
I don't know whether I should. No, I've not set this my new laptop. You know, when I come back, I'll do it. Come on,
We're
close the
waiting
door.
for Prof to be back. Colleagues, please remember to drop your questions in the Q&A box. And also just look at the chat box. I'll also reshare the attendance link for everyone who has not yet filled the attendance to do so. So, yes. Okay, so I think we'll leave the presentation where it is and maybe start answering some questions. Thank you so much, all our presenters so far, and also colleagues online for the patience. So we'll just quickly go through some questions, and I see there is one question with regards to who actually appoints an IPC focal person, whose responsibility, the NCDC team or hospital management. And I would like Dr. Ezeman from the NAF Military Hospital in Makurdi to answer this based on your experience, sir. Over to you, Dr. Ezeman.
All right. The person that appoints the IPC focal person is the administrator of the facility, the most senior person. If it's in teaching hospital, the CMD, if it's in a military facility, is the commander, because he needs that authority for him to operate at that level. And then the committee must also have a representative that reports directly to whoever is the head of the facility. So that's very important, because if a lower cadre or person appoints the IPC focal person, may not have that drive that authority from the system and may not be able to push the IPC program in the facility. Thank you.
All right, thank you so much. I believe there's still another question. And so while Dr. Tochi is trying to reach Prof, please, if you can just answer this question, then with regards to, there's a question on the IPC diploma course, and I know you are a trainer, train some people. So there's a question with regards to how do they register to enroll in this? I don't know if you can also answer this question.
All right, for the IPC program, it's actually the diploma course is organized at the University of Lagos, and the Orange Network can actually support. If your facility is a member of the Orange Network, it becomes easier for you. Otherwise, if you are the IPC focal person, when they annually, when they release the adverts, they usually share it among the facility, the Orange Network facilities, and I can also go to the website and then get that. And then when we apply, if you are qualified based on what we are doing, because it is meant for people who are working in the IPC program within the country. So that's the way to go. So the first thing is that you have to be in the IPC program. You have to also get yourself linked to the Orange Network to make it easier for you to actually re-enroll and have that diploma. You have the basic, you have the intermediate, and then you have the advanced.
Yes, thank you so much for providing clarity and answers to those questions. So Dr. Tochi, while we're still just waiting for Prof to probably wrap up, can we just answer? You have a lot of questions here for you specifically. Is it okay if I read them out and provide answers?
Yes, please read out and I will attempt to answer.
All right, thank you so much. So I think there's quite a lot of interest from what I see in enrolling institutions, the Orange Network. There was a question with regards to, sorry, just bear with me one moment. Yes, there's a question with regards to knowing, someone wants to know if Federal University, I think FUHSO, if they are on the list of the IPC Orange Network. Some other people also want to know, as they're an occupational health and safety trained professional, would they be incorporated? Is it possible for them to be trained as an IPC focal person? I'm just trying to see again. I know there is also a question. Okay, so I think this for now are the ones I can really see. But I remember there was also one with regards to just knowing if, like, with the ongoing engagement of CMDS, that's the last one, how many tertiary institutions have a functional IPC? I know you had presented this, probably the person missed the presentation, or specifically just wanted to know how many tertiary institutions or facilities, healthcare facilities, are part of the network currently. Thank you.
Okay, thank you very much for reading out those questions, and I thank colleagues that raised the question. Let me take a minute to explain the concept of the Orange Network, because I believe that it will help to make things clearer. So, first of all, every hospital leadership can immediately set up their own IPC program in line with the WHO core components. It's not, the more people, leadership of hospitals are able to do this on their own, the better for us. That's actually where we want to end up with, where hospitals, as part of what they do routinely, as part of providing quality healthcare, are able to have within their their organogram, their IPC teams, their IPC focal persons with their terms of reference, with their job description, and also with their key performance indicators being linked to the work they do as IPC teams. That's the vision. We, at the National IPC program, because there was nearly non-existent IPC programs in health facilities across the country, and because of the complex nature with which the complex nature of healthcare provision in the country, secondary, tertiary, public, private, different levels being controlled or being regulated by different levels of the government. So we asked ourselves, how do we strengthen this? How do we kickstart this process of having IPC programs in hospitals, given this complex terrain? And then we realized that if we can identify what a group of hospitals or health facilities have in common, whether it's a common location, geographic location, or it's okay, Prof is back. Let me just finish my line of thought, and Prof, you can take over. Then we form them into these networks, and we work with them gradually, incorporating one component after the other to bring them to the centers of excellence. But our email address will be shared after this, hopefully. So anybody that contacts us, any state that contacts us, we can support the state IPC focal person to set up the networks in all their tertiary, in all the hospitals controlled by the state. And the beautiful thing with the state is that the state also controls the private hospitals, and we are open to working with states to set up state IPC programs, support states with with IPC programs in all their hospitals, private hospital associations that approach us, we can support. So we are open to provide that support and guidance. We have a lot of guidance documents that we're ready to also deploy, and training programs. So I'll hand over to Prof now, who is back. Thank you.
All right, thank you so much, Dr. Tucci, for answering those questions. Prof, you're welcome back.
Thank you very
We missed
much.
you at this very point. But then I was also made aware that you still have about 23 slides left. Is it possible for us to just have a kind of a wrap-up or conclusion? I know this is the last presentation, and probably others might have eaten into the time, but we're just trying to make sure that we also keep to the time here as well. All right, thank you, and over, Prof.
Okay, so I'm going to rush through the remaining slides. Let's get to the next one. The point here is hand washing is, it's a key pillar. Now, the other aspect of, yes, let's go to the next slide. The other aspect of IPC that we must talk about is the issue of risk assessment and use of PPE. Before we attend to any patient, first we must ask ourselves a few critical questions, which will help us to assess the risk at the point of care. What level of contact am I going to have with this patient? What procedure am I going to perform? Is it likely there will be splash? Will there be potential for needle stick injury? Will there be aerosols from this patient? And what are the available PPEs that I have? We must ask all these questions before we begin to manage the patient. Next slide, please. And once we have done that, we should be able to make our choice of PPEs. This slide essentially shows us the range of PPEs that we have, and depending on the risk that we expect from the patient, we should be able to make a choice. Next slide. The next slide shows us this range of PPEs, and also how we can choose the type of protective wear that we need, depending again on whether we expect to be soiled from the patient, whether we expect aerosols, and so on and so forth. Next slide. Next slide, please. So on the next slide, for Lassa fever in particular, you would see that it is not for every procedure that you will require the full range of PPEs. And this slide essentially guides us through what nature of PPE we can use depending on our exposure level to the patient. And if you're doing a screening, you can see that you will need essentially all the PPEs. But if you're just doing general nursing care, you may not need to wear some of them. Next slide, please. Yeah, now how do we strengthen occupational safety in practice? There are three key domains that I'm presenting here. The first one is to reinforce our standard precautions in terms of hand hygiene, in terms of disinfecting the surfaces and contacts, and also the use of appropriate PPE. The second one is behavior change and risk communication. The issue of training has been very well emphasized by Professor Ogoshola, and we cannot emphasize it enough. Training and retraining. Over time, we have observed that there is a gap between training and practice, and it is this gap that retraining seeks to fill. We must design new messages so that our messages do not begin to sound like a broken record. We must continue to design messages, reinforce old messages, design new messages, especially taking into consideration the local circumstances and that people can understand. And then the SOPs, the standard operating procedures, must be in place, and we must enforce them. The third domain here is how to manage contacts and our and other healthcare workers. Routine disinfection, segregation of our waste at the source of production, and then when health workers come in contact or they are exposed to patients, we must consider what form of post-exposure prophylaxis becomes necessary. Next slide. Now, this is an example of one of such messages that we have designed during one of the outbreaks. As you can see from this slide, which was directed at university students, this is their backyard filled with filth where these rodents can feed. And with the Japa syndrome, as you can see, students travel a lot. So the picture here is metaphoric, showing that this person is carrying the virus with her and traveling all over. And that can also explain how some of these outbreaks start. Next slide, please. We should manage our waste very well. This is a key factor in safety, because we don't want these materials to come in contact with healthcare workers. And sharp boxes are provided everywhere. You can see that we must provide the waste bins and of the appropriate color where we generate this waste. Next slide. This table shows us the recommended cleaning and disinfection frequencies for surfaces, which should be at least twice daily. For general nursing care area, at least once daily. And each time that we have visibly soiled surfaces, we must clean. For linens, we must apply every patient as a new linen, because we do not want to transfer patients to linen that has been soiled by other patients. And then, of course, we must clean the toilets at least twice a day, and each time they are visibly soiled. For isolation areas, this is more vigorously emphasized, and we must keep cleaning and recleaning as the need arises. Next slide, please. These are the appropriate PPEs that needs to be used and the disposal materials required for disinfecting surfaces. Next slide. Now, the next slide brings us to a very important point when it comes to healthcare safety. We must audit our facilities, and this has to be a routine. Now, the WHO has provided us with a standard guide on how to carry out this assessment, but that tool is very bulky, and for a daily use, what we have done at our center is to reduce these over 20-something items to about the 10 most important ones, which will be the hand hygiene tools, IPC posters and guidelines, staff training on IPC, access control around cases, water supply, disinfection and cleaning, visitors access and control, IPC team functionality, use of PPE, healthcare waste management, and the triage area. And the next slide will show you how we have applied this at the center. What we have done here is that we devised a scoring system where 0 means that the standard is non-existent or is not met, and then 1 means that they've met some of the standards, 2 means that it adequately meets the recommended standard with a maximum score of 20. The table shows the scores for the various units that were assessed: male surgical ward, female surgical ward, children emergency, and so on. And we have used all the criteria I read out before to assess this. Now, on the basis of the score, we have assigned a risk matrix. Red indicates that it is below 50%. Yellow means that it's between 50 and 79%, while green means that it is 80 and above. So if it is 80 and above, that means you just need continuous improvement. For the yellow, action is needed. For red, it becomes an emergency and you need to take action immediately. The next item we'll look at is occupational safety challenges. What are the challenges? Many of these challenges have already been mentioned, so I'll just rush through them because of time. The first one is limited access to PPEs. Sometimes, even when these PPEs are available, people don't know how to use them. Then we talk about insufficient training and awareness. Healthcare workers often do not receive adequate training, and many times they assume they know when they don't really know. And so there is need to really emphasize this training and retraining. Then the issue of inadequate implementation of IPC measures. Many centers lack a robust IPC protocol, and for many, SOPs are not available, or when they're available, they don't adhere to them. So these are challenges. Other challenges include staff shortages, high workload, because the number of health workers are few, workload is high. And when workload is high, fatigue sets in. And as we know, once people are tired and stressed, they are more readily to be careless about adhering to protocols. And so they are at higher risk. Then we talk about inadequate surveillance and reporting systems. The surveillance systems are there to give us information in real time. And when this information is not, the data is not generated or data is not analyzed, then we fail to see the danger in real time. And especially in response to outbreaks, we may not be able to see it forthcoming and respond appropriately. Then the issue of stigmatization and fear is very real. You may not appreciate this until when you come in contact with a confirmed case. During one of the outbreaks, we had the health workers who admitted a patient during the night, and by morning they realized that this patient died, and when the samples came out, it was positive, and health workers began to immediately begin to take prophylaxis, and some were coming down with the consequences and side effects from this panic intake of prophylaxis. So it is real, and we must address it if we want to promote occupational safety, particularly for healthcare workers. The next slide shows us some of the tools we have used to investigate health worker exposure. When we have this kind of scenario, it is important to use a simple tool, such as the one that is on this slide, and then they can fill in this tool to say exactly how they have been exposed. Because if they had just probably, maybe the exposure is just taking history from the patient, it's different from when you have maybe carried out some procedures like maybe intubation, or maybe you have inserted NG tube and so on. So on the basis of that, you can categorize the exposure into green, yellow, and red. And on the basis of this, a decision can be made as to who needs prophylaxis, who needs a daily temperature check, and who needs just mere reassurance. So the challenges, there are some challenges that are faced by health workers in promoting their own safety. And some of these relate to healthcare infrastructure, particularly wash infrastructure. WHO has emphasized that wash in particular is key to the maintenance of IPC in all hospitals. We had the privilege in 2021, I believe, to carry out a national assessment, next slide please, of the wash status in all the federally owned tertiary facilities. And as you can see from the results, in terms of water, we found high performance in less than 10% of all the health facilities. And more than half of them had just moderate performance, over 30% with low performance. In terms of hygiene, high performance was recorded in only about 12%, and 2/3 of the health facilities assessed had low performance. Some of the pictures that we got from these facilities they are so terrible that I'm not sure I'll be able to show them here. But the summary is that health wash infrastructure is at an abysmal low in many of our health facilities, and something needs to be done urgently. Next slide. And this something that needs to be done involves collaborative efforts for us to sustain change. If we want change in our IPC status and in the safety of our health workers, then stakeholders must work together to bring about this change. We want to commend the efforts of the NCDC and the Federal Ministry of Health and other NGOs who are already doing this. The presentation by Dr. Tochi highlights the kind of multi-stakeholder engagement that I'm talking about. And this is critical if we are to improve health worker safety, particularly against Lassa fever. For us to address this, in the next slide, we have proposed some measures that can be taken. The first one is enhancing training. And I'm again very happy that Professor Ogushola dealt extensively on this issue. We cannot run away from this because we must continue to train and retrain our healthcare workers. Collaborative research. This is also one area that there are gaps. We must encourage research on innovative ways by which we can improve IPC, health worker protection in our health facilities. This will lead to strengthening of IPC, as you'll see in the next slide, and strengthening IPC infrastructure, providing WASH as a starting point, and PPEs and all other infrastructure that supports the protection of healthcare workers is critical if we are to address this problem. So we must, as a matter of fact, begin to take steps to provide adequate protective gear for our health workers. Next slide, please. The psychosocial support for health workers is one area that has been taken for granted. And you need to be at a center with a high volume of patients when it comes to, particularly during outbreaks, to appreciate what I'm talking about. Health workers are humans, and many times they suffer psychosocial illnesses on account of the exposures that they get every day from Lassa fever patients. I would like to, at this point, acknowledge the great work that is being done by Dr. Okogbeni and her team in this area. It has provided a lot of succor for health workers. And the issue of panic, I recall that in 2018, during that major outbreak, there are times when patients are brought in and health workers begin to scamper because they are afraid for their lives. And we saw it clearly during COVID. So there needs to be psychosocial support that is instituted, that is used in a systematic way in every health facility to provide for healthcare workers so that they do not go through psychosocial trauma and they can have the that support, which is very highly needed. Finally, I like to call for action, and this action begins with limiting exposures for you as an individual, that individual healthcare worker. You must limit your exposure, and that emphasizes your responsibility to yourself, your responsibility to yourself, your responsibility to your family, your responsibility to your fellow healthcare workers. And how do you embrace this responsibility? You embrace this by ensuring that for every patient that you attend to, you apply all the IPC protocols. You ensure that you communicate the risk to other healthcare workers. And so we must also advocate a culture of safety within the health facility. A situation where we say IPC does not matter. In such facilities, you are bound to have very high number of health worker illnesses and exposures, and ultimately health worker occupationally acquired Lassa fever. And so for us to achieve this, there has to be very clear policies and protocols which are enforced. And we must provide reward for performance, reward for excellence. Those who have taken the pains to promote IPC, to ensure IPC, we must acknowledge them, we must reward them. And then, of course, there has to be comprehensive education and training. And finally, we should identify areas by which we can continuously improve. On this note, I would like to thank all of you for your attention, and once again to thank Dr. Tochi and our team for inviting me. Thank you very much.
Thank you so much, Prof. Thank you for that wonderful presentation. Colleagues, apologies, we have eaten a bit into your time, but we'll be wrapping up very shortly. So a lot of questions that were placed in the chat box, you answered in the course of your presentation. And in a way, I think this question has been answered, but if you could just reiterate as well. Someone asked, what is the minimum number a team of IPC should have and the criteria for the selection of the team, the IPC team within a healthcare facility. So over to you, Prof.
Okay, in terms of number, I think what we should bear in mind, which to me, my mind is more important, is the representation in the team. For an IPC team to function, it must have people who are trained or who have the skills in and who represent the relevant areas. In my presentation, I did mention some of the high-risk areas within each health facility. The IPC team should have representations from each of those units. And in addition to that, the IPC team should have representation from management at the highest level. Ideally, the CMD or the head of the hospital should be the chairman of the larger IPC body, while the day-to-day IPC team can be led by the infectious disease doctor or the public health doctor. But in terms of numbers, there are these factors to consider. And then the size of the hospital. In a small hospital, of course, you don't expect that you'll have large numbers, but the key people should be represented on the team. Over to you.
All right, thank you so much. Thank you so much, Prof, for that answer. So this takes us now to the conclusions and wrap up. And this will be presented by Dr. Ladun, the head of the Department Surveillance and Epidemiology from NCDC. Over to you, Ma.
Dr. I would like to start by saying thank you to everyone that's been part of this webinar, for staying with us since the beginning, and apologies for eating a little bit into your time. First of all, let me start by saying a big thank you to all our esteemed speakers, from Professor Ogunshola, the VC, Unilag, as well as the chair ICANN. Thank you, Ma. We appreciate your time as well as your contribution towards IPC in the country and as well as on the global level. I would like to also appreciate Dr. Izima, the IPC focal person for Makodi. Thank you for your delivery on the benefits of IPC programs in healthcare facilities. And a special thanks to our last speaker for today, Professor Vivian Haba, the Deputy Vice Chair Academics, Federal University of Health Science, Otugbo, for sharing from your wealth of knowledge as regards strengthening occupational safety, regarding preventing and managing healthcare worker acquisition of Lassa fever. We appreciate you. And lastly, to our own IPC chair for the country, as well as the chair AMR Coordination Committee for Nigeria, Dr. Tochi Okwo. Thank you for all your efforts on the IPC project, for pushing forward a lot of together. And my application and towards your contribution to the success of the webinar on the IPC caused by Lassa fever across the country. Across all our speakers, we noted one particular key message across all the speakers is very clear that the knowledge and the practices of IPC are very essential in preventing nosocomial spread of infections at our health facilities. And it's important for us to remember that IPC is everybody's business. It's not just a one-off. It's a norm and it's not an exception. So together, in our own little practice, in our own healthcare facility settings, let's ensure that we continue to turn Nigeria orange by ensuring that we keep to the practices of the IPC in our day-to-day activities and businesses. As we conclude this webinar today, I would also like to encourage each participant to play their own vital role in not just hearing this information, but ensure that you disseminate the information and the knowledge that you've acquired here within your organizations and within your communities to ensure that we continue to contribute to the broader effort to mitigate the impact of Lassa fever in the country. It's important to remember IPC is not a one-time endeavor. It requires a continuous process, demands our vigilance, adaptability, as well as collaboration. And Prof noted in our presentation that we cannot move from 0 to 100%. There are processes and there are minimum requirements of IPC settings that needs to be in place. And it involved trained manpower, it involved resources, and it involves the need for us to have focal persons at different level of healthcare settings across our health facility. So I want to encourage every participant to stay connected in our own field. Let's continue to dialogue and continue to engage in ongoing research and initiative related to Lassa fever and IPC, and ensure that we foster a community of shared knowledge and experience so that we can collectively continue to contribute to the development of more effective prevention and control measures. So in closing, while wrapping up, my appreciation also goes to the Lassa fever TWG. You've been consistent in putting together this webinar series, and this is the third one. And we look forward to the next series in the next 2 weeks. Well done to everyone. Let's continue to carry the spirit of collaboration forward and continue to work together to build a healthier and a more resilient future. Thank you all for your effort, and thank you everyone for joining today's session. See you once again in 2 weeks' time. Thank you, and over.
Thank you very much, ma'am. Bye, everyone.
Bye.